In this lecture, I will be discussing 10 MCQs on a very important and exam productive topic, hernia. Hello viewers, this is Dr. Rajiv. Welcome to your education channel YouTube Surgery and Orthopedic Education. Please consider subscribing to it and sharing it with your near and dears to help them prepare not only for the MBBS course but also for other postgraduate and medical job entrance examinations. Please don't forget to hit the bell icon below so that you never miss useful lectures from us. Mesh is a prosthetic material, either in the form of a net or a flat sheet, used to strengthen a hernia repair. The ideal mesh for hernia repair should possess several key characteristics to ensure effectiveness and safety. The mesh should be biocompatible to minimize the risk of rejection and infection. The mesh should be chemically inert to avoid reactions with body tissues. It should not have any adverse effects or be carcinogenic. The mesh should have high tensile strength and endurance to withstand mechanical stress while remaining sturdy. The material should be easily sterilizable and adaptable to the needs of the repair. Lightweight, large pore mesh is often preferred as they cause less discomfort, reduce the risk of chronic pain, and are more flexible, integrate better, and shrink less. The term lightweight and large pore size are used extensively in literature with no precise and official definition. However, meshes less than 40 gram per square meter are generally referred to as light and meshes more than 80 gram per square meter as heavy. Application of Pascal's law allows us to understand the biomechanics of mesh placement in abdominal wall hernia repair. To understand, we take an example of a bathtub. When there is a leak in the bottom of a bathtub, it is better to repair it by sealing the defect from inside. If the seal is applied from outside, the pressure of the water will push the seal outwards and the repair is likely to fail. The same scenario can be imagined while placing a prosthetic mesh on a hernial defect. If a mesh is applied from inside as an inlay, it gets firmly fixed when the intra-abdominal pressure rises. On the other hand, an onlay mesh repair is likely to result in a recurrence of hernia if excessive rise in abdominal pressure takes place. Pascal's law is utilized in the technique of traditional stoppage preperitoneal repair as well as in modern laparoscopic ventral hernia repair (LVHR), such as in intraperitoneal onlay mesh or iPhone technique. It is also important that the mesh overlaps the edge of the defect by at least 3 to 5 centimeters to allow Pascal's forces to act evenly on the mesh. An indirect inguinal hernia is the most common hernia overall, regardless of gender. Also, indirect hernias are the most common type of hernia in women as well. Although femoral hernias and umbilical hernias occur more frequently in women than in men, inguinal hernias remain the most common hernia in women. Femoral hernias are rare in males. TAXES is a manual reduction method to replace incarcerated contents under analgesia and sedation from a hernia sac into its natural place. TAXES technique can be safely attempted early on after the onset of symptoms and is effective in about 70% of patients. The patient is placed in Trendelenburg position. TAXES technique begins by palpating the facial defect around the base of the hernia and gently manipulating hernia contents back into the abdominal cavity. Gentle manipulation pressure is continued for 5 to 10 minutes until a gurgling sound is heard, indicating successful migration of the bowel. The Kugel and McVeigh procedures are for hernia repair, not for reduction. These are not popular today due to high recurrence risk. The Stopa procedure is a very safe repair method for bilateral inguinal hernias. It is also known as giant prosthetic reinforcement of the visceral sac. A strangulation without obstruction is typically seen in Richard's hernia. In this hernia, there is entrapment or a strangulation of a part of the bowel's antimesenteric wall in the hernial defect site, often without causing complete luminal obstruction. It causes rapid ischemia without causing intestinal obstruction. There is often lack of symptoms and signs of intestinal obstruction, leading to delay in diagnosis and serious complications such as bowel gangrene and perforation. Early recognition of the condition and prompt surgical intervention are crucial for successful management and happy outcome. A femoral hernia arises in the femoral canal. The differential diagnosis of femoral hernia includes direct inguinal hernia, an enlarged lymph node of cloquet in femoral canal, saphenous varix, aneurysm of femoral artery, psoas abscess, an enlarged psoas bursa, a lipoma around femoral canal, and hematoma in adductor longus. An enlarged gland of cloquet within the femoral canal simulates exactly an irreducible femoral hernia. Lumbar hernias occur in the lumbar region of posterior abdominal wall. Most common site of origin of primary lumbar hernias is through the inferior lumbar triangle of Petit. The Petit triangle is bounded by the iliac crest, latissimus dorsi muscle and external oblique muscle. Second most common site is through the superior lumbar triangle or Greenfeld triangle. Weakness of the lumbosacral fascia through either of these triangles is the main cause of a lumbar hernia formation. Primary lumbar hernias are rare. Secondary lumbar hernias are incisional hernias arising through flank incisions for renal operations or through incisions for harvesting iliac crest bone grafts. A small lumbar hernias are frequently asymptomatic. Larger hernias may cause back pain. CT scanning is useful for diagnosis. Both open and laparoscopic repairs are successful. Umbilical hernia is a common condition, occurring in up to 10% of infants. There is a higher incidence in premature babies. Obstruction or strangulation is extremely uncommon. No surgical treatment is indicated under the age of 2 years if the hernia is symptomless. Reassurance and conservative treatment is all that is necessary. 95% cases will resolve spontaneously. Surgical repair is indicated only if the hernia persists beyond the age of 2 years because then it is unlikely to resolve by conservative means. The femoral ring refers to the base of the femoral canal, which is part of the femoral sheath and lies medial to the femoral vein. It is bounded anteriorly by the inguinal ligament, posteriorly by pectineal ligament, and medially by the lacunar ligament. Laterally there is femoral vein. The femoral ring is a site of potential weakness in the groin for femoral hernia formation. Repeated forceful cuffing or straining during pregnancy and parturition forces the loop of intestine into the femoral ring together with the parietal peritoneum. This forms a femoral hernia sac which descends in the femoral canal and bulges forwards and suprolaterally if the hernia sac continues to enlarge. Consequently, a retort-shaped or U-shaped femoral hernia appears. Paraduodenal hernias are rare internal hernias occurring through left and right paraduodenal foci. Here, a portion of the small intestine pushes through a defect near the duodenum. The cause of these hernias is the failure of descending or ascending colonic mesentery to fuse with the posterior parietal peritoneum. This condition is relatively rare, but can lead to serious complications such as bowel obstruction and infarction. Left paraduodenal hernia is commoner than right paraduodenal hernia. Left paraduodenal hernia is a hernia into the descending mesocolon, where the small intestine herniates through a defect in the mesentery in the left paraduodenal fossa near the ligament of Treece. The left paraduodenal fossa is also known as fossa of Langerhans and the right one as fossa of Cobb. Treatment is bowel reduction and obliteration of the hernia defect by simple closure or by wide opening of the sac. Thank you so much for watching. Please subscribe and stay tuned for more educational videos.